Hi everyone, welcome back to the channel. Today we're diving into the basics of ECG interpretation. ECG stands for electrocardiogram. It's a non-invasive test that records the electrical activity of the heart using electrodes placed on the skin. Before we dive into ECG interpretation, let's take a moment to understand electrode placement and how that relates to the concept of leads. In a standard 12-lead ECG, we place 10 electrodes on the body. We start with 4 limb electrodes, 1 on the right arm, 1 on the left arm, 1 on the right leg, and 1 on the left leg. The right leg electrode doesn't contribute to the ECG tracing. It serves as a ground. The other 3, right arm, and left leg, are used to generate the lymph leads. Next, we place 6 chest electrodes, called the precordial electrodes, directly on the chest. V1 goes in the 4th intercostal space just to the right of the sternum. V2 also goes in the 4th intercostal space, but just to the left of the sternum. V4 is placed in the 5th intercostal space along the mid-clavicular line. V3 goes midway between V2 and V4. V6 goes at the same horizontal level as V4, but on the mid-axillary line, right under the middle of the armpit. And V5 sits midway between V4 and V6. Together, these 10 electrodes gives us the data we need to create 12 electrical views or leads of the heart. The lymph leads look at the heart from the frontal plane. Lead 1 compares left arm to the right arm, lead 2 compares left leg to the right arm, and lead 3 compares left leg to left arm. Then we have the augmented leads. Lead AVR views the heart from the direction of the right arm, lead AVL from the left arm, and lead AVF from the feet, or the left leg. And the precordial leads view the heart in the horizontal plane. Leads V1 and V2 focus on the septal region, the wall between the right and left ventricles. Leads V3 and V4 look at the anterior wall of the left ventricle. And leads V5 and V6 give a view of the lateral wall of the left ventricle. Next, let's take a look at the ECG paper itself. Vertically, the graph measures voltage or amplitude. Each small box is 1 mm tall, which equals 0.1 millivolts, or MV. So a large box, which is 5 small boxes high, equals 0.5 millivolts. Horizontally, the graph measures time. Each small box is 0.04 seconds, or 40 milliseconds. A large box is 5 small boxes wide, which equals 0.2 seconds. Every ECG tracing is made up of a repeating pattern of P, QRS, and T waves. Each part represents a specific electrical event in the heart. The P wave represents atrial depolarization, initiated by the sinoatrial node, or SA node. As this electrical signal spreads across the atria, the atrial muscle contracts and pushes blood into the ventricles. The PR interval is the time it takes for the impulse to travel from the atria through the atrioventricular, or AV node. The AV node deliberately slows conduction, which allows the ventricles enough time to fill with blood before they contract. The QRS complex marks ventricular depolarization. The impulse leaves the AV node and travels down the bundle of His, then splits into the right and left bundle branches, and finally spreads rapidly through the Purkinje fibers. The result is a powerful contraction that pumps blood into the aorta and pulmonary artery. The ST segment reflects the period when the ventricles are fully depolarized. Elevation or depression of this segment can indicate ischemia or infarction, which will be talked about later. Finally, the T wave represents ventricular repolarization. This is when the ventricular muscle returns toward its resting state. The ventricles relax, their pressure falls, and blood begins flowing in from the atria to prepare for the next cycle. An ECG is simply a recording of electrical waves. If depolarization moves toward a lead, you see a positive deflection. If it moves away, you see a negative deflection. Now that we understand the basics of the ECG paper and waveform components, let's move on to a simple step-by-step system to read any ECG. We use the mnemonic RRIIRHA. Each letter helps guide you through ECG interpretation. We start with R for heart rate. We typically examine lead 2, since it aligns with the heart's natural electrical impulse, which travels from the upper right atrium downward to the left. There are 2 common ways to estimate rate. Count the number of R waves in a 10-second strip and multiply by 6, or divide 300 by the number of large boxes between 2 R waves. A normal heart rate is between 60 and 100 beats per minute. If the rate is under 60, that's called bradycardia. If it's over 100, that's tachycardia. The second R in our mnemonic stands for rhythm. We check if the heart is in sinus rhythm, which means that the electrical signals are being generated by the sinoatrial node, the natural pacemaker of the heart. To confirm sinus rhythm, we look for three main features: regular RR intervals, a P wave before every QRS complex, and a positive P wave in lead 2, since it looks at the heart from the lower left side, in the direction of normal atrial depolarization, and a negative P wave in AVR, since it views from the right shoulder opposite the direction of atrial flow. If these conditions are met, we call it normal sinus rhythm. Next, I for the key intervals. The PR interval is normally between 0.12 to 0.2 seconds, or 3 to 5 small boxes, whereas the QRX duration should be less than 0.12 seconds, or under 3 small boxes. The QT interval should normally be less than half of the preceding RR interval. If the QT interval is greater than that, we call it QT prolongation. Common causes include medications such as antiarrhythmics, including Class 1A like quinidine, procainamide, Class 3 like amiodarone and Satilol, certain antibiotics such as macrolides and fluoroquinolones, antifungals like fluconazole and ketoconazole, antipsychotics like haloperidol, and antidepressants like tricyclics or SSRIs. Other causes include electrolyte abnormalities, including low potassium, low magnesium, or low calcium, and congenital conditions like congenital long QT syndromes. Now let's classify bradycardia patterns based on rhythm and intervals. If the rhythm is regular and the PR interval is normal, that's most likely sinus bradycardia. Other common causes of bradycardia involve the AV block, or atrioventricular block, which is a type of conduction abnormality where the electrical signal from the atria is delayed or completely blocked as it travels through the AV node to reach the ventricles. We classify AV blocks into 3 degrees. First degree AV block is the mildest form. In this case, every atrial impulse is still conducted to the ventricles, but the conduction is delayed. On ECG, you'll see a prolonged PR interval greater than 200 milliseconds, while the rhythm remains regular. Second degree AV block is more serious. Here, some atrial impulses fail to reach the ventricles, so not every P wave is followed by a QRS complex. We subdivide this into 2 types. Mobitz type 1 shows progressive prolongation of PR interval until a QRS is dropped. Mobitz type 2, on the other hand, shows sudden dropped QRX complexes without prior PR lengthening. This type is more dangerous and often requires pacing. Finally, third degree AV block, also called complete heart block, is the most severe. In this condition, there is complete dissociation between the atrial and ventricular activity. The P waves and the QRX complexes march independently. This almost always requires immediate pacing. Now let's classify tachycardia, which we define as a heart rate greater than 100 beats per minute. We organize tachycardias based on 2 things: the rhythm regularity and the QRS width. First, regular narrow complex tachycardias. Sinus tachycardia is the most common. It's usually a normal response to fever, exercise, or anxiety. You'll see upright P waves before every QRS. Other examples of narrow complex regular tachycardia are supraventricular tachycardias, which originate above the ventricles. A common type is atrioventricular nodal reentrant tachycardia, abbreviated as AV and RT, caused by a reentry circuit within the AV node. On ECG, the P wave is usually not visible because atrial and ventricular depolarization occur almost simultaneously, so it becomes hidden within the QRS complex. Another important type is atrioventricular reentrant tachycardia, abbreviated as AVRT, which involves a reentry circuit using an accessory pathway. The most common form is orthodromic AVRT, in which the impulse travels down the AV node and hits Purkinje system to activate the ventricles, and then returns retrogradely up the accessory pathway to activate the atria. This results in a narrow QRS tachycardia with inverted P waves appearing just after the QRS, best seen in the inferior leads. Atrial flutter, or AFL, is caused by a macro reentrant circuit in the atria, which presents as classic sawtooth flutter waves, most visible in the inferior leads. The ventricular response is usually regular. Second, narrow complex but irregular rhythms. Multifocal atrial tachycardia, or MAT, is common in patients with COPD. You'll see at least 3 different P wave morphologies and an irregular rhythm. Atrial fibrillation with rapid ventricular response, or AFRVR, happens when chaotic atrial activity causes the ventricles to beat too fast. There are no distinct P waves, the baseline is chaotic, and the ventricular rhythm is irregularly irregular. Third, white complex and regular tachycardias. The big one here is ventricular tachycardia, or VT. It arises from the ventricles, so the QRS complexes are wide, usually more than 120 milliseconds, and the rhythm is very regular. This is a life-threatening emergency. Finally, white complex and irregular tachycardias. The most classic example is polymorphic ventricular tachycardia, including torsade de pointe, which means twisting of peaks in French. It is usually triggered by QT prolongation mentioned earlier. A prolonged QT interval increases the risk of early after depolarizations, which can give rise to abnormal ventricular beats, where the QRS complexes gradually change their amplitude and appear to twist around the baseline. This rhythm is unstable and can quickly deteriorate to ventricular fibrillation, which is a chaotic, disorganized ventricular electrical activity that results in no effective cardiac output and cardiac arrest. PVCs, or premature ventricular contractions, are early beats that originate from the ventricles. On ECG, they appear as wide, bizarre QRS complexes without a preceding P wave, usually followed by a compensatory pause. They can occur occasionally or frequently, with variable rate and patterns. A widened QRS complex may also occur in a bundle branch block, which is a conduction delay in either the right or left bundle branch. To identify a bundle branch block, we focus on leads V1 and V6. In V1, which sits over the right ventricle, the QRS is normally negative, because the electrical activity moves away from that lead. In V6, which sits over the left ventricle, the QRS is normally mostly positive, because depolarization is moving toward that lead. In the right bundle branch block, or RBBB, the left ventricle activates first while the right ventricle is delayed. In V1, you see the classic rapid ears pattern, which includes a small R from septal depolarization, then an S from left ventricular activation, and finally a tau R from the delayed right ventricle. In V6, the early part of the QRS looks normal since the left ventricle depolarizes normally through the intact left bundle. But the delayed right ventricular activation sends an electrical vector away from V6, giving a broad S wave. In the left bundle branch block, or LBBB, the right ventricle activates first and the left ventricle is delayed. In V1, the delayed left ventricular activation dominates and creates a deep downward complex. And in V6, there's no normal small Q wave, because the septum depolarizes in the opposite direction. Then the delayed left ventricle finally depolarizes, creating a broad tau notch R wave. The second I in our mnemonic stands for ischemia, a condition where the heart muscle isn't getting enough oxygen supply to meet its demand. Before we dive into ischemic patterns on ECG, we first need to understand the coronary arteries because they are the ones supplying oxygen to the heart. There are three major coronary arteries. The left anterior descending artery, or LAD, supplies both the septum, which is represented by leads V1 and V2, and the anterior wall of the left ventricle, represented by leads V3 and V4. The left circumflex artery, or LCX, mainly supplies the lateral wall of the left ventricle, which is represented by leads 1, AVL, V5, and V6. The right coronary artery, or RCA, supplies the inferior wall of the left ventricle, represented by leads 2, 3, and AVF. It also supplies the right ventricle, which we can see using the right-sided chest leads, V3R and V4R. These are simply mirror positions of V3 and V4 placed on the right side of the chest, and they are especially important when we suspect a right ventricular infarction. Finally, the posterior wall of the left ventricle may be supplied by either the right coronary artery or by the left circumflex artery, depending on coronary dominance. We don't see posterior leads in standard 12-lead ECG, but we can infer posterior involvement from reciprocal ST depression in the anterior leads V1 through V3. Now let's talk about myocardial infarction, a condition where a lack of oxygen leads to cell death and electrical changes in the heart muscle. Myocardial infarction is generally divided into two main categories: ST elevation myocardial infarction, or STEMI, and non-ST elevation myocardial infarction, or non-STEMI. STEMI is marked by hyperacute T waves in the early minutes. These are tall, broad-based T waves caused by very early localized potassium leakage from injured myocardial cells, which makes repolarization look exaggerated in that region. Besides STEMI, hyperkalemia can also produce tall peak T waves, since high extracellular potassium lowers the resting membrane potential and makes repolarization much faster than normal. The key difference is that hyperkalemic T waves are usually very narrow and pointed, while STEMI hyperacute T waves are usually broad. As the infarction progresses, you'll see ST elevation within hours. We identify ST elevation by comparing the J point, which is the junction of the QRS and ST segment to the baseline of the PR segment. The cutoff values for ST elevation vary depending on age, gender, and which leads you are looking at. For men under 40, the cutoff is 2.5 mm or more in leads V3 and V4, and greater than 1 mm in all other leads. For men older than 40, the cutoff is greater than 2 mm in V3 and V4, and again greater than 1 mm in other leads. For women, the cutoff is a little lower, greater than 1.5 mm in V3 and V4, and greater than 1 mm in other leads. ST elevation has to be seen in at least 2 contiguous leads to qualify as STEMI. Not all ST elevations mean myocardial infarction. The shape of the ST elevation is very helpful. A convex or tombstone-shaped ST elevation is more likely to represent an acute STEMI. On the other hand, a concave ST elevation can be seen in conditions such as benign early repolarization, which is usually localized, and acute pericarditis, in which inflamed pericardium produces diffuse, widespread ST elevation across multiple leads. Now let's move on to non-STEMI. Unlike STEMI, where we see ST elevation, the earliest ECG change in non-STEMI is usually ST depression caused by subendocardial ischemia. When looking at ST depression, the morphology is very important. Downsloping or horizontal ST depression is much more specific for ischemia. Upsloping depression, on the other hand, is often non-specific and may even be normal with exercise. The definition of ST depression is greater than 0.5 mm in leads V2 and V3, or greater than 1 mm in all other leads. And like ST elevation, it must be present in at least 2 contiguous leads. After ST depression, another finding you may see in non-STEMI is T-wave inversion. It reflects abnormal repolarization of the ischemic myocardium. The injured cells alter the direction of repolarization, so the T-wave flips upside down. T-wave inversion can also be seen in hypokalemia and digoxin toxicity. Next up in our mnemonic is R for R-wave progression and pathological Q waves. Under normal circumstances, the R-wave amplitude increases gradually from lead V1 through V6. It reflects the direction of ventricular depolarization. The electrical impulse moves from the right side of the heart toward the left ventricle, which has much more muscle mass. But when this pattern is disrupted, we call it poor R-wave progression. Several conditions can cause this. An O anterior myocardial infarction is one of the most important. If the anterior wall is scarred, it can no longer generate a normal R wave, so the amplitude stays low across the precordial leads. Left ventricular hypertrophy, or LVH, can also alter the pattern. Because the left ventricle is so thick, the transition point shifts later, making the early leads show smaller R waves than expected. And in right ventricular hypertrophy, or RVH, the right ventricle becomes dominant, producing larger R waves in V1 and poor progression across to the left. Now let's talk about the pathological Q wave. A Q wave is the first negative deflection that appears before the R wave in the QRX complex. Normally, it represents septal depolarization. A Q wave becomes pathological when it meets any of these criteria. Rather than 0.04 seconds, that's one small box on ECG paper, or deeper than 0.2 millivolts, that's 2 small boxes in depth, or its depth is greater than 25% of the total QRS amplitude. These abnormal Q waves are the most significant when they are seen in the anterior leads, especially V1 through V3. The classic cause of a pathological Q wave is an old myocardial infarction. When part of the myocardium becomes necrotic, it can no longer depolarize. Instead, the ECG records only the forces moving away from the infarcted area, which shows up as a deep, wide Q wave. Pathological Q wave can also be seen in left ventricular hypertrophy, or LVH. In this case, the thickened left ventricle alters depolarization vectors, producing Q waves in the septal leads. Another possibility is hypertrophic cardiomyopathy, or HCM. Here, the abnormally thick septum generates exaggerated early depolarization forces, which can mimic pathological Q waves. Next in our mnemonic is H, which stands for hypertrophy. On the ECG, hypertrophy of the atria or ventricles produces characteristic changes that we can recognize. In left atrial enlargement, the P wave becomes wider than 0.12 seconds and often looks bifid or M-shaped in lead 2. This happens because the left atrium depolarizes later than right atrium. And when the left atrium is enlarged, the second half of the P wave is stretched out, making the overall P wave wide and notched. In right atrial enlargement, the P wave is taller than 0.25 millivolts in lead 2. This is because an enlarged right atrium generates a stronger initial depolarization factor, so the early part of the P wave shoots upward, making it unusually tall and peaked. In left ventricular hypertrophy or LVH, the S wave in V1 or V2 plus the R wave in V5 or V6 adds up to more than 35 millimeters. The reason is that the thickened left ventricle produces a much stronger leftward depolarization factor. This deepens the S waves in the right-sided leads and enlarges the R waves in the left-sided leads. In right ventricular hypertrophy, or RVH, you'll see that in V1 or V2, the R wave becomes taller than the S wave. At the same time, in V5 and V6, you'll see a very steep S waves. This pattern occurs because the enlarged right ventricle dominates the electrical forces. Instead of depolarization moving leftward as usual, it moves more to the right. So the early chest leads show a tall R wave and the left-sided leads show a deep S wave. Finally, in our mnemonic, A stands for axis. Determining the QRS axis tells us the overall direction of ventricular depolarization, and it can give us important clues about underlying heart disease. The simplest way to check axis is look at whether the QRS complex is positive or negative in lead 1 and lead AVF. If lead 1 is positive and lead AVF is also positive, that's a normal axis. It means depolarization is moving leftward and downward, which is the usual direction of the heart's electrical activity. If lead 1 is negative and lead AVF is positive, that's a right axis deviation. Common causes include right bundle branch block or RBBB, right ventricular hypertrophy or RVH, and right anterior fascicular block or RAFB. If both lead 1 and lead AVF are negative, that's called an extreme right axis deviation, sometimes referred to the northwest axis. One important cause to remember here is ventricular tachycardia, or VT. If lead 1 is positive but lead AVF is negative, that's a left axis deviation. This can be seen in left bundle branch block, or LBBB, left ventricular hypertrophy, or LVH, and left anterior fascicular block, or LAFB. However, to confirm left axis deviation, you also need to make sure that lead 2 is negative. And that wraps up our step-by-step guide to ECG interpretation using the RRII-RHA mnemonics, which stands for rate, rhythm, intervals, ischemia, R wave progression, and pathological Q waves, hypertrophy, and axis. By following these steps in order, you'll have a structured approach that helps you quickly get an overview of the patient's heart condition. Thanks for watching, and I'll see you in the next one.